Sarah.
And I'm Claire, and today we're here to talk to you about coronary artery disease, the leading cause of death in the United States, and how it anatomically develops in the heart. We will first provide an overview of the heart and its systemic and coronary circulations, and then discuss how this physiology is impacted by coronary artery disease.
Looking at this model, you can see that the heart is located in the mediastinum, from the second rib to the fifth intercostal space. 2/3 of the heart, it lies to the left of the midsternal line, and the apex is on the bottom while the base is at the top portion by the right shoulder.
The heart has 4 chambers, 2 atriums, and 2 ventricles. The atriums are called receiving chambers because they receive the blood returning to the heart from circulation. On the other hand, the ventricles are discharging chambers because they pump blood out of the heart into circulation. The right atrium is here. The vessels that enter the right atrium are the superior vena cava, the inferior vena cava, and the coronary sinus on the back. The left atria and the left ventricle pump blood to the aorta, while the right ventricle pumps blood to the pulmonary trunk. Both atrium have auricles and are small, thin-walled chambers. Ventricles have thicker walls than atriums.
So how do these 4 chambers relate to how blood flows through the heart?
Well, there are 2 circuits, the pulmonary circuit and the systemic circuit. The pulmonary circuit includes vessels that carry blood to and from the lungs, and the systemic circuit includes vessels that carry blood to and from all body tissues.
For the pulmonary circuit, the right atrium receives oxygen-poor blood from body tissues throughout one of the 3 vessels that enter the heart as mentioned before. The blood is then pumped through the tricuspid valve into the right ventricle and through the pulmonary valve into the pulmonary trunk. It then flows through the pulmonary arteries into the lungs where it becomes oxygenated. This circuit is a short, low-pressure circulation.
Circuit, the oxygenated blood flows from the lungs through the pulmonary veins into the left atrium. This is pumped through the tricuspid valve into the left ventricle and then through the aortic valve into the aorta to be pumped into body tissue. Unlike pulmonary circulation, this circulation encounters more blood flow resistance and higher pressure circulation.
So now you know the passage of blood flow through the body. How is the heart itself supplied with blood? Why can the heart not be supplied through the above circulation?
Although the heart is always filled with at least some blood, this blood is not able to nourish the heart due to the fact that the myocardium is too thick for diffusion. This is where coronary circulation comes into play. Coronary circulation is the system of blood vessels that allows for the myocardium to have a supply of glucose and oxygen that it needs while also providing a drainage system. So, as you can see in this model, the arteries that are involved in coronary circulation are the aorta, the left coronary artery, the right coronary artery, the right marginal artery, the posterior interventricular artery, the circumflex artery, and the anterior interventricular artery.
As the oxygenated blood leaves the left ventricle and travels up into the aorta, some of it will branch off into the left and right coronary arteries. Once blood enters the right coronary artery, it can branch off into either the marginal artery or the posterior interventricular artery. Blood from these 2 arteries supplies the right atrium, right ventricle, SA node, and AV node. On the other side of the heart, once blood has entered the left coronary artery, it will either end up in the circumflex artery or the anterior interventricular artery. Together, these 2 arteries supply glucose, oxygen, and drainage system to the left atrium and the left ventricle.
Once the designated areas have used up the glucose and oxygen in the blood, a way to drain the byproducts is needed, and it's when the veins are needed. The veins involved in draining the myocardium are the small cardiac vein, the middle cardiac vein, the great cardiac vein, the coronary sinus, and the anterior vein. The small cardiac vein, the middle cardiac vein, and the great cardiac vein all drain into the coronary sinus. The coronary sinus then drains into the right atrium, where it mixes with blood from the superior vena cava and inferior vena cava. The anterior vein, unlike the 3 cardiac veins, drains directly into the right atrium without joining into the coronary sinus.
Thus, the heart receives its blood supply through coronary circulation. But what if the heart muscle cannot receive the oxygen it needs? This can happen through coronary artery disease. Coronary artery disease occurs when arteries that supply blood to the heart become hardened and narrowed. So how does this happen? Through atherosclerosis.
Atherosclerosis is a type of arteriosclerosis. Arteriosclerosis is a broad term for the thickening and hardening of arteries. In atherosclerosis, small, patchy thickenings called arthromas form. These patches intrude into the vessel lumen, creating a blood clot or closing off the vessel completely.
Atherosclerosis can occur in any artery in the body, but the vessels most susceptible to atherosclerosis are the aorta, the coronary, and carotid arteries. Hence, it is a big problem for coronary circulation. Now that you know what atherosclerosis is, how does it progress? Atherosclerosis progresses in 4 stages.
This is a healthy vessel, but the first stage of atherosclerosis is the injury of the endothelium of the vessel. This can be due to a variety of factors, including blood-borne chemicals, viral or bacterial infections, cigarette smoke,
Turbulent blood flow.
or turbulent blood flow, yeah. This then causes the immune system to be triggered, setting off an inflammatory response process.
The second stage occurs when lipids accumulate and oxidize in the tunica intima of the vessel. The injured endothelial cell will release chemotactic agents and start transporting and modifying lipids picked up from the blood. Specifically, low-density lipoproteins, or LDLs, are picked up, and this accumulation of LDL oxidizes in the inflammatory environment. LDLs are lipoproteins that deliver cholesterol to tissue cells via the bloodstream. Then the oxidation of LDL will damage neighboring cells, which act as chemotactic agents in attracting macrophages. The influx of macrophages that flood to the site will become so engorged with LDLs that they will transform into lipid-laden foam cells. An accumulation of foam cells forms a fatty streak, which is the first visible sign of an atheroma.
In the third stage, smooth muscle cells migrate from the tunica media and deposit collagen and elastic fibers into the innermost layer of the artery wall. The thickened intima, called a fibrous or atherosclerotic plaque, has a core of dead and dying foam cells. Initially, the vessel wall will try to accommodate the glowing plaque by expanding outward, but eventually the plaque becomes so large that it will protrude into the vessel lumen, as you can see here, which then proceeds into atherosclerosis.
The fourth stage is the growth of plaque. If the plaque continues to enlarge, the cells in its center will die, calcium will be deposited, and collagen fiber production declines. Over time, the plaque will accumulate fat, cholesterol, calcium, cellular waste, fibrin, and other substances found in the blood. As the plaque hardens, the arteries narrow, limiting the flow of oxygen-rich blood to organs and other parts of the body. So, see, it's narrowing. While plaque can partially block the blood flow, it can also completely block blood flow in the artery. In the event that a piece of plaque breaks off or a blood clot forms on the plaque surface, the artery will become blocked, causing a heart attack. This plaque is called a complicated plaque because it's unstable and prone to rupture at any time.
This reduction of blood flow can lead to myocardial ischemia, preventing the heart from receiving enough oxygen. The reduced blood flow is typically the result of a partial or complete blockage of your heart's arteries, coronary arteries, which blocks the coronary arterial circulation.
So myocardial ischemia, which is also known as cardiac ischemia, can damage your heart muscle. We already know that fatty buildup in the coronary arteries decreases blood and oxygen delivery to cardiac cells. However, this becomes a problem because the heart will become hypoxic and begin contracting ineffectively. Thus, a sudden and/or severe blockage of the coronary artery can lead to a heart attack.
To summarize, coronary artery disease and coronary heart disease are ischemic heart diseases caused by narrowed arteries and less blood and oxygen flow to the heart muscle. Silent ischemia is also something that many Americans face. They may have silent ischemic episodes without suffering any pain. Often, this occurs because plaques that are extremely small, too small to be seen on a traditional angiogram, will be present. If they rupture and form a clot, these people can have a heart attack without any warning.
Additionally, people who have had heart attacks or live with diabetes are at higher risk for developing silent ischemia. People with angina also may have undiagnosed silent ischemia. Performing an exercise stress test or wearing a Holter monitor, a battery-operated portable tape recording that measures and records your electrocardiogram, or ECG, are 2 tests often used to diagnose silent ischemia.
What can severe ischemia cause?
As you have learned, the buildup of atherosclerosis can cause a fleeting deficiency of blood delivery to the myocardium. This can lead to pain or discomfort in the thoracic cavity, the chest, called angina pectoris. Many factors can intensify this pain, including stress, exercise, and any other type of demanding physical activity. This pain, however, does not necessarily indicate a myocardial infarction or the death of cardiac cells. Instead, myocardial cells are temporarily weakened by this lack of oxygen.
A myocardial infarction is caused when the ischemia of the heart exceeds a critical threshold, overwhelming the mechanisms that keep the heart flowing normally. The oxygen-rich blood to a section of the heart becomes blocked.
If this occurs for 20 or more minutes, permanent myocardial cell damage and death will occur. Cell death occurs first in the endocardium, the inside. The severity depends on the length and location of the attack, along with if there is collateral damage, with attacks in the left ventricle being the most lethal. The dead cells are replaced with non-contractile scar tissue. Thus, ischemia and infarction can lead to arrhythmias.
An arrhythmia is an abnormality in the normal sinus rhythm, otherwise known as an abnormality in the normal activation sequence of the myocardium. MIs and infarctions can result in a biochemical change within and outside of the cell, including acidosis, increased catecholamine release, and certain changes in cation concentration. This leads to electrical changes and destabilizes the heart and causes arrhythmogenesis, or the formation of arrhythmias.
There are three types of arrhythmias: automaticity, triggered activity, and reentry arrhythmias, which can be benign when there is no heart disease present. However, MIs and changes in the electrical stabilization of the myocardium can lead to development of ventricular tachyarrhythmias, which can lead to sudden cardiac death. So, thank you for listening to our presentation, and if you have any questions about coronary artery diseases, let us know.
From the start,